Hi everybody, you are listening to the Medea podcast series. Medea Medical Education Academy is a global medical education provider dedicated to designing, delivering and evaluating medical education programs worldwide. Today we are going to speak with Doctor Salman Razvi, Senior Lecturer in Endocrinology at Newcastle University and Consultant Endocrinologist and Director of Research and Development at Queen Elizabeth Hospital NHS Trust, Gateshead, UK. This podcast, TSH, The Impact of Increasing Age and Increasing Weight, is part of the continuing medical education program entitled Blended Learning Journey on Thyroid Disorders.
Hello, everyone. It's a great pleasure to be here with all of you. I'm Salman Razvi. I'm an endocrinologist and a senior lecturer in Newcastle University in the northeast of England. Today, we'll be talking about the impact of age and weight on serum TSH levels. This podcast is targeted for clinicians involved in endocrinology, particularly those treating thyroid disorders and also people in general practice. And some content would be of interest to clinical and research scientists and those involved in the care of people with pregnancy and managing older individuals. The objectives of this podcast is that everyone at the end of the podcast should be able to critically evaluate the TSH reference range and know the starting point that should be viewed in relation to the individual circumstances and the medical history of each individual patient. And the second objective is to appreciate how certain life phases, such as pregnancy and older age, impact on TSH levels.
Can you explain what happens to TSH levels as patients age and how this is important when assessing older adults for thyroid disease?
So I think it's important to start with how reference ranges in general are calculated. The reference ranges are standards that are utilized to compare each individual value. So what do I mean by that? So we have somebody who has had a blood test, the TSH comes back as 3.2. Now, what does that number 3.2 mean? We need a comparison to evaluate this number against. So the reference ranges are generally provided by a group of individuals without known thyroid disease who have their blood test taken and their thyroid function is ranked from the lowest to the highest, and individuals from the 2.5th percentile to the individual with the 97.5th percentile are taken as the lower and the upper limit of the reference range. What that means is automatically the middle 95% of population who are considered free of thyroid disease are taken as a reference range. So using this process, the TSH reference range is normally taken as 0.4 to about 4 to 4.5 milliunits per liter. So this is how the TSH reference range is calculated globally. The second part of this, which is also important, is why do we use TSH as a reference range when we want to measure somebody's thyroid hormone status? This is because thyroid hormones themselves have a wide reference range, and individuals have high inter and intra-individual variability. TSH is a very sensitive marker of thyroid hormone status. So what that means is that for a twofold change in T4, you get an almost 100-fold change in TSH. To put that in context, if somebody's T4 halves, you get a 100-fold rise in a person's TSH. And conversely, if somebody's T4 doubles, you get a 100-fold reduction in TSH. So the TSH is a very, very sensitive marker of tissue thyroid hormone status. Now, moving on to the question about how does TSH change? So age isn't just the only factor that impacts on TSH. There are several factors that impact on TSH, and we're talking about some of these in due course. Age is one of the main ones. The other factor that impacts on TSH is body weight. There are several others, such as illnesses, medications, time of sampling, pregnancy being another one, iodine status, and so on. With regards to this particular question about how does aging have an impact, Age throughout the lifespan has an effect on TSH. Babies have a high TSH when they're born, and TSH levels tend to get lower through childhood. And around the age of 17 or 18, they level out. And then around the age of 50, 55, they start rising up again. And 60, 65, 70 is when they start growing up quite substantially. There have been a number of studies that have looked at the effect of age on the TSH reference ranges, and we've talked previously about how these reference ranges are calculated. If you look at all adults as one homogeneous group, then the reference range tends to be about 0.4 to 4.5. However, if you break that down by different age groups within adults, in older people, the upper end of the TSH reference range invariably tends to be higher than 4.5. And there have been many studies that have looked at this. Some have used, or found levels of 5.5 in people in their 70s or 80s, and some, particularly from the NHANES study in the US, have even detected levels of 7 or 8 being the upper end of the normal reference range. What effect does this have on diagnosis of somebody with thyroid disease? It depends on what reference range we use. So if you use the commonly used global reference range for all adults, then we tend to overdiagnose older people with hypothyroidism because the TSH levels tend to be higher. So if somebody has a TSH of 5.5, if they're in the 20s, that may well be high for them. But if they're in the 70s or 80s, that is probably normal. And if you don't use the appropriate reference range, they could be diagnosed as having hypothyroidism, and in general, it's typically subclinical hypothyroidism they might be diagnosed with. Now, what impact does that have? It could mean that some people might be started on treatment with levothyroxine when they actually don't really need it. And that may be one explanation for why prescriptions for levothyroxine have generally been increasing over time. And there is some evidence that suggests that a threshold for starting people on treatment has been getting lower in terms of TSH levels over the years. Does it really help these people? Evidence obtained recently from randomized controlled trials suggests that if you do treat older people, and when I say older, it's typically above the age of 65, the evidence is particularly stronger for people in their 80s. It doesn't really have any beneficial impact on symptoms or their quality of life. So what it means is that if you have an individual with a TSH that's marginally elevated and you end up treating them with levothyroxine, it's not going to improve their quality of life any more than what you would do without treating them.
What about the impact of obesity on TSH levels?
So just like age has an impact on TSH levels, the body weight of the individual also has an effect. So both people who are underweight, and the best example are people with anorexia nervosa who tend to be underweight, their TSH levels tend to be low. There could be several reasons for this in people who are underweight. It could be nutrition, it could be the effect of the anorexia itself on the hypothalamic pituitary thyroid axis. But as people gain weight, and particularly we're talking about the effect of obesity, so BMI greater than 30, TSH levels tend to be higher. The thinking or the evidence behind this is that the fat that is present is chemically active. It produces adipokines, and leptin tends to be one of the adipokines that's implicated in the effect on TSH. Leptin stimulates TRH, or thyrotropin releasing hormone, release from the hypothalamus. TRH increases both TSH production as well as prolactin production, and that leads to an increase in TSH as well as free T3 levels. Free T3 levels tend to be also high in people with obesity because TSH as well as leptin increases the deiodinase process of converting T4 into T3. So again, is this compensatory or is this pathological phenomena? We don't really know, but it's thought to be compensatory mechanism of obesity having an effect on thyroid function, which means that TSH tends to be higher. Now, what impact does this have on clinical practice? What it does do is that people who have obesity, and that obesity might be due to lifestyle, which is probably the common culprit in most circumstances and generally around the world, might be looking for reasons for their weight gain. And one of the most common blood tests that's checked tends to be thyroid function, and TSH levels might be slightly high in people with obesity. And one of the effects of finding a slightly high TSH in somebody with obesity could be that it's thought that it's the high TSH that's causing the obesity, and therefore treatment is instituted with levothyroxine therapy. Now, evidence from randomized controlled trials suggests that the effect of thyroxine therapy in subclinical hypothyroidism is minimal, and in general, there's no effect or minimal effect in terms of 1 or 2 kilograms of weight loss, which is really not a lot. However, on the contrary, there are many studies from weight loss drugs. There are studies from bariatric procedures that suggest that significant weight loss actually leads to a reduction in serum TSH levels. In fact, there is one study of individuals that have had bariatric surgery that has shown that every individual that had subclinical hypothyroidism pre-bariatric surgery after weight loss actually had normal TSH level. So what this means is that in people with obesity, the TSH reference range again might be higher, and using the standard TSH reference range that we have from the general population may not be appropriate, because once again, what we're doing is two things. One is these people might be started on levothyroxine therapy with the expectation that this will help with their body weight, and in reality, it hardly ever does. And that could prompt the patient to start thinking that the levothyroxine isn't working. Whereas, in fact, the reality is that the TSH was never the cause of their weight gain in the first place, and it was the other way around. The other thing is in those people that have started treatment with levothyroxine, they might start thinking of other options that could help with their body weight, and they might be looking at other less evidence-based options to treat themselves for their thyroid condition, which actually isn't pathological, but is compensatory and probably physiological for them. And weight loss by any other means would probably be more beneficial.
What special considerations should be given to TSH levels in pregnancy?
So pregnancy is another condition where thyroid function changes. And the reason for this is that the fetus needs thyroid hormones, particularly for its neural development during the first trimester in particular. And during those first 3 months of pregnancy, the growing fetus is relying exclusively on the mother's thyroid hormone levels to help its neural development. So as part of this, the TSH levels tend to be lower and T4 levels tend to be higher. And this is predominantly due to the effect of beta-HCG, which is similar to TSH levels in its action and also in structure. So what this leads to is lower TSH, a higher T4, and therefore if you were to check thyroid function in somebody who's pregnant, you would find that the TSH levels generally tend to be lower than in a non-pregnant state. So therefore you need pregnancy-specific reference ranges, and pregnancy also as well as trimester-specific reference ranges. So a TSH level that may be normal in a non-pregnant person may actually be abnormal in somebody who's pregnant. And there have been studies that have suggested that individuals with a slightly higher TSH could have adverse neural cognitive impact on the baby. And there have been at least 2 trials that have shown that treatment in people whose TSH is higher than the pregnancy-specific reference range, particularly if the TPO antibody is positive, would be beneficial. And this is what the guidelines also indicate.
We've spoken about age, obesity, and pregnancy. What about menopause?
Menopause is a condition that all women go through around the age of 45 to 55 in general, and it's associated with a number of hormonal changes. Main one, obviously, is the reduction in estrogen, which leads to a compensatory rise in gonadotrophins in general and FSH in particular. This is associated with a number of symptoms. And around this time, when there are symptoms, women might get a number of blood tests, and thyroid function could be one of the blood tests that's checked at this stage. In general, the menopause doesn't tend to have a direct effect on TSH levels, but it could be that because a lot of women are having their blood checked at this point in time, due to the symptoms, and the symptoms of menopause could be weight gain, could be fatigue, could be not sleeping well, which kind of overlap with symptoms of hypothyroidism. A number of women who might have these symptoms will also have marginal TSH abnormalities detected, not because that's being caused by the menopause, but it's a kind of detection bias because they're having it detected around this particular time in their lives. So again, it could be that at this point in time, they're having symptoms, and treatment of these symptoms, which are predominantly due to their menopause, with levothyroxine is not really going to have a major impact because those symptoms were never related to the thyroid abnormality in the first place. And HRT might be something that would have been beneficial, but if you substitute that with levothyroxine, it might not have an impact. And again, patients might start wondering that their levothyroxine isn't working, when in effect, it wasn't really the levothyroxine that was the culprit, or the TSH wasn't the culprit in the first place, and it's probably more related to the menopause. So the menopause is a state of flux. There are lots of things going on at this stage, and detecting of mildly abnormal TSH is probably a bystander effect due to higher detection bias rather than a direct cause and effect in this group.
What take-home messages do we have at the end of this podcast?
I think there are a number of take-home messages. The first and the major one is that for each individual, the TSH reference range should be individualized. So in young children, in pregnant women, in older people, the TSH reference range needs to be different than the, say, wider general population. Take into account the patient's symptoms, their age, the actual level of TSH. In general, if the TSH is higher than 10, then that's probably abnormal, irrespective of the age of the patient. But if it's less than 10, and if there is obesity or somebody is in their 80s, then it's very likely that it could just be a normal variation due to their weight or due to their age. And treating everyone using the same yardstick isn't helpful. And particularly if you're going to start treatment, then this will be lifelong, and potentially it could cause harm, which we shouldn't really be even considering. The second take-home message would be really levothyroxine treatment needs to be considered as an actual drug rather than hormone supplement. And the long-term effects of treatment, the benefit as well as the adverse effects should be considered. Treatment and over-treatment does have adverse effects on bone health, on heart rhythm health, and so on. So it's not without its downside. So we need to be careful in identifying the right person that we should be treating, and equally, and probably more importantly, identifying the person who may not need treatment is also critical.
Thank you for listening to this Medea podcast. For more information about our continuing medical education programs, please visit our website at medeaacademy.com.